remission or stopping your treatment is a possibility for some of our patients with CML now. So it used to be that really everybody was advised they would need to stay on the tablets lifelong, but we've got good clinical trial data now that shows us that a proportion of patients can safely stop their treatment and keep their good responses, and carry on just with monitoring without having treatment on a long-term basis. But this isn't suitable for everybody, so we have to be careful about which patients this is going to be safe and appropriate for. But it's something that you might want to discuss with your team if you've been on treatment for a number of years and you know that you're responding well. So the eligibility does depend a little bit on which drugs that you've been treated with, but in the main, patients who've been on imatinib will need to have been on treatment for around 5 years. On the second generation drugs, sometimes a little bit shorter. And what we're looking for is that your PCR response is in major molecular remission, but ideally a level below that, so in the sort of what we call the MR4 level, so a slightly deeper level of major molecular response is the safer place from which we might be able to have a think about making changes towards stopping. So I think it's important to say there is no pressure to stop, there is no agenda to stop, and a lot of people don't really feel comfortable about stopping, and that is absolutely fine. So if your team bring this up with you as a possibility, it is absolutely okay to say, no, I don't want to stop. For whatever reasons I have, I think I'd be better off continuing. There's no financial pressure, fortunately, for us that says that we have a feeling you should stop. So it's a really individual decision, and it's just not right for everybody. But for some people, it can be an approach that they want to take. So there's different ways to go about it. If your team feel that you may be eligible because you have this level of good response, you may halve the dose of your drug first and have a period where you're on a lower dose with slightly tighter monitoring. Or alternatively, you can stop your therapy completely, literally go from your full dose one day to not taking anything the next day. And both approaches are valid. Both have been trialled and shown to be safe. I find a lot of patients in our clinics prefer the option of halving their dose first and seeing how that goes before they come off completely. But again, it's a matter of personal preference. And there are pros and cons to this. So the obvious pro is that we know that side effects reduce when you drop your dose of treatment or come off your treatment completely. And sometimes I think people who've been used to putting up with quite a lot of side effects, things like the fatigue or the lack of concentration or the muscle cramps, they don't really realise how much they've been putting up with until it's not there anymore. So sometimes the lifting of the side effects feels really good day to day. And also it reduces the chance of perhaps longer term, more hidden side effects, things like effects on your blood sugar or your cholesterol or your blood pressure. It takes that out of the equation if you're drug free. So there's an advantage to go for. But there are some downsides. And I think there's 3 main downsides. One is a bit of a withdrawal syndrome. One is the frequency of monitoring. And the third is the sort of psychological well-being. So if we talk about those in turn, withdrawal syndrome certainly doesn't happen to everybody. In our experience, it's about a third of patients will get a bit of withdrawal syndrome, and it generally shows as muscle or joint pains. I find people describe it quite a lot in their shoulders or arms, but also legs equally can be affected. And it can be enough to sort of stop you in your tracks a little bit. It can be painful enough to need regular painkillers or anti-inflammatories. Sometimes we'll treat it with a course of steroids, but it's generally self-limiting. It doesn't harm the joints or muscles, and it will usually resolve over a period of weeks to months. But it's something to bear in mind. And then the second factor is the frequency of monitoring. So if you stop your drug completely, we need to monitor you monthly for the first 6 months. And that's really important because most of the cases where we get what we call molecular recurrence, so the trace of your PCR can increase, that will mostly happen in the first 6 months. But we need to still keep quite a firm handle on what's happening to your PCR after that. So quite frequent monitoring through the rest of that first year and the next year 2 and year 3. And the monitoring really needs to carry on lifelong. So although this looks like cure, you're not on your drug anymore, your disease is at very low level or even undetectable, we can't quite sign you off and lose you from the clinic. We still need to monitor because there's a very occasional case where the levels will pick up again 8-10 years down the line. So we just need to be mindful of that. And then the last factor is how this sort of fits in with your psyche. And some people who found their diagnosis quite stressful and then found they really liked the fact that their disease was so well controlled might not want the uncertainty of suddenly going back into the headspace where they're thinking, well, what's my next result actually going to be? It can be very comforting to go through months or years of always being told in clinic, yes, your results are great, your results are great. It's a nice, safe place to be. And it's a bit disconcerting to then think, oh, every month, what's my result going to be? What's my result going to be? It doesn't suit everybody, and it's worth just predicting how that might feel for you. So the absolute key thing with trials of stopping is timing. You don't want to be stopping when you're about to move house, when you're about to have a baby, when you've got other health issues going on. It's a question of finding the right timing where if you do get some withdrawal syndrome, it will be manageable, where your headspace is good to sort of live with the uncertainty, and then it can all fall into place when the timing feels right for you. Having that acceptance really going into it that it only pans out for roughly a half of people. So we know from the data that roughly a half of people will have to go back on their drug because their levels do go up. And that's not a failure, it's just life, that some people's disease just won't behave quite as well and they will need to go back on their medication. So it's just having an awareness again of how that might make you feel. What we're finding now is just because you need to go back on therapy, that might not be lifelong, and we're getting more data coming through now about having a second attempt at stopping, and that can be successful. So as more time goes on and you're back on your drug for a few years, it may be possible to have another try. So it's a work in progress as you go through your CML treatment. But if it's something you're interested in, having a think about treatment-free remission, then please bring it up with your clinical team. So one thing your team will need to decide if you're off treatment and your levels are creeping up is when you may need to go back on your drug. And the trials were mainly designed around loss of the major molecular remission point at the cutoff where you should be back on your drug and back on your drug quite quickly within a month so that we get you securely tucked back down again. And that's how we know that it's safe. So again, it can be a little bit nuanced or individual. So some people, if they see their traces increasing, they might not want to wait until they lose their major molecular remission. They may just think, oh, I don't like this, I want to go back on drug, and that's fine. But we do find there's some patients where their levels rise and then they just bobble around just on the cusp of major molecular remission, but patients do keep it and can keep it for years. So again, it's a little bit fluid and it's a little bit of dialogue, but we do know that if you go above the major molecular remission threshold, the trial data would suggest we should get you back on your drug, and in that way your levels will go back down, and we know that it's a safe thing to do.